Hello, everyone. Thanks for joining us for this session. I'm Ali Hussein from NYU. I'm a transplant nephrologist. I'm both the moderator for the session and the first speaker because my talk will hopefully set the stage for what Drs. Purnell and Dr. Menon will talk about in terms of solutions to fix the transplant system in the United States as best as we can. I have high hopes for the talks. We'll do a group Q&A at the end, so please hold all of your questions for any of the speakers to the end. We'll have about 15 minutes for questions and answers. But you might be wondering why we have to have a session in the first place about how can we improve the transplant system. So I think I first need to convince you that maybe the system is not functioning as well or as poorly as you think it might be. To start out with, I have no disclosures, and I think that there's basically two perspectives on how the transplant system is functioning now that people may have. So one is this, which is the kind of, I think, the most frequent public perception I get from people I speak to these days, which is that the whole thing is a mess. Which is, I can't say I completely disagree with, but maybe not always a totally accurate characterization. But you see tons of headlines in popular media about how dysfunctional everything is. And actually, because of that, in 2025, we saw the largest year-on-year decline in deceased organ donation in US history. On the other side, if you talk to any transplant surgeon or transplant nephrologist, many of them will say, I don't understand what the big deal is. We're doing more transplants now than ever. In fact, in the past 2 decades, transplant volume has about doubled. And so what is everyone complaining about when we're doing so many more transplants? And so the objectives of this talk, sorry, I see Jeff's in the audience. I didn't do my objective slide second, but I had to set that up. The objective of this talk is to talk about why it's important that the public trust the transplant system, talk about what's changed over the past decade or so, and to describe kind of ongoing challenges that hopefully Drs. Purnell and Menon will have great solutions for. But to start with, so we're all on the same page, kidney transplant is better than dialysis in every single way for a patient who is eligible. Most notably, the survival with transplant is way better than with dialysis. You can see with, oops, let's see if I have a long enough pointer here. With either deceased or living donor transplant, the survival is much better than with either PD or HD. This extends the quality of life, it extends the cost of care for the payer, so it's really a win in every way for the eligible patient. Unfortunately, there's a huge shortage of kidneys available for transplant in the US. You can see that on average now, there are about 20,000 more patients added to the list each year than there are transplants performed. So everyone between these two lines are people who die on the wait list without getting a transplant. Further, there's a rising proportion of transplants that are deceased donor transplants rather than living donor transplants. So for the past 25 years, basically, living donation has been stagnant. And you can see this top line here, the total rise in kidney transplant has been entirely driven by a rise in deceased donor transplant. And that's important because that means that however we decide as a community to allocate kidneys, essentially decides who gets the survival benefit of transplant and other benefits, and who will instead die without a transplant or die before getting the opportunity to get a transplant. And so that's a really big decision of who should be prioritized for an organ. And it must balance like various competing goals. So utility in terms of like overall utility for the system, equity and access, and even simple things like logistics. We can't have kidneys routinely flying back and forth from Honolulu to New York every day. And these goals and the complexity of these goals are specifically charged to the Organ Procurement and Transplantation Network by what's called the final rule. So I won't go through these in detail, but there's a whole section in the regulation about transplant about the allocation of organs and what principles it must adhere to when it's designed. But beyond being important because it's the rule that it has to be functioning well, I would say it's also very important for the transplant system health in general. So this data is a little bit old, about 18 years, but I think is the best done and kind of the most recent on this topic. But this is from Ebony Boulware, in which she surveyed 845 randomly selected US adults and asked them, like, do you think allocation is fair, basically? And only about a quarter of people said yes, which is really low for something that we depend on the public to buy into, right, in order to become organ donors. And in fact, 41%, so you might think that if some of these unshores are actually a no, maybe at least half are believing that they don't think allocation is fair. And that's, like I said, important for the health of the system because addressing that perceived fairness, I believe, might help impact people's willingness to participate in the system. So here's, so the US federal government does periodic surveys about attitudes towards organ donation. And one of the questions they ask people who are not registered donors, it's like, would anything change your mind to make you want to become a donor? And one of the 2019 survey questions was about this. And in fact, like almost half the people said, like, yes, I might be able to change my mind. But many of those who said yes to this question had deep skepticism about the medical system. And so I think it's logical to believe that improving trust in the system can improve donation and improve the health system overall. And so the system is constantly trying to improve over time, I would say. I'm going to walk you through maybe the last 15, 12 years of those changes. So the biggest one since I've been in transplant was in December 2014, when the kidney allocation system, or what we call CAS, was implemented. And we'll talk about what it did in a second. But you can see that this large allocation system change that happened in 2014 was expressly trying to accomplish some of those goals that we talked about as being kind of assigned to the OPTN in the final rule. So you can see, I left the gray text in so no one can accuse me of taking things out of context. The black text is what you have to read. But you can say, when they're saying, why is CAS necessary? They said there's higher than necessary discard rates. So we talked about utility. There's variability in access to transplant. There's inequities. There's unrealized life years, which is utility. And they predicted that their modeling predicted that this would result in 9,000 additional life years of transplants per year. So clearly, utility and equity concerns they're trying to address. And so what that allocation system change did was make a couple of really fundamental changes in how we allocate organs. So there were two that were related to equity and access. So the first and most important was that waiting time for a transplant was now backdated to whenever you started dialysis if you were listed after you started dialysis. So what that means is, prior to CAS, if I got waitlisted today but I had 5 years of dialysis time, I had 1 day of waiting time tomorrow. After CAS, I had 5 years and 1 day of waiting time tomorrow because of that backdating. The other was that they added heavy priority points for patients who are heavily allosensitized, because previously, because they're eligible for so few organs or compatible for so few organs, they had a really tough time accessing transplants. And then finally, there was a small utility component too. So they did the first kind of real longevity matching for adult kidney transplant candidates, where they took the top 20% of donated kidneys in terms of expected lifespan after transplantation, the top 20% of kidney transplant candidates in terms of how long they would expect to live after transplant, and said those 20% of candidates get first pass of those top 20% of organs. And the idea is that you want to kind of give those long-lasting organs to younger, healthier people. That way they get the most life years of transplant out of those grafts. And what I hope to convince you is that any time a policy change is made, it accomplishes exactly what it intends to do and nothing else. And so what you can see is that after CAS, I'll walk you through this figure. So in the top, I told you, there's this priority change for highly sensitized candidates. What happened is, pre-CAS, each of these dots is a center. Pre-CAS, all the heavily sensitized patients, so these dark green dots, had much lower center level expected probability of transplant, the y-axis probability of transplant, than their non-sensitized counterparts. Whereas post-CAS, and this is obviously a lot of noise here because there are very few patients, but post-CAS you can see basically these lines overlap. So they got brought up in their transplant rates. Similarly, pre-CAS, no matter how much dialysis time you had at the time of listing, you had the same time to transplant. Now, these pink ones, people who have a lot of pre-listing dialysis vintage, they have higher probabilities of transplant than people who have less. So we made a rule, and exactly what that rule kind of intended to happen is what happened, but nothing else. And one of those residual issues was geography. And so prior to, and we'll talk about this in a lot more detail, but prior to CAS, it was known that there's large geographic inequities in access to transplant. And since CAS did not intend to address that, you can see here that there's essentially the same, each of these is a donation service area. We'll talk about what that is in a second. But in each geographic unit of allocation, there was the same geographic inequities that occurred before CAS, which makes sense, right? We didn't try to change that. Well, not me, because I was not involved, thankfully. But that was a problem because the OPTN's final rule specifically says that where you live should not influence your access to transplant. And so in order to understand why these geographic differences happened, we need to understand a little bit about how allocation works. And so prior to 2021, this is how allocation works. So right now, this first part's true even now, but kidneys are recovered by organ procurement organizations, or OPOs. These are federal nonprofit contractors responsible for recovery and allocation within a specified geographic region called a donation service area, or DSA. And so prior to 2021, when a kidney is recovered by an OPO within their DSA, that kidney was offered to every candidate within that DSA first, and then within a larger region, and then finally nationally if no one else wanted it. And so in order to understand why that might be a problem, you need to understand what the DSAs look like. And you can see they're very strangely shaped for complicated reasons, but you see some are within states, some are cut across states, some states have multiple. And if you see even regions are a little bit easier to understand, but kind of have what are ultimately going to be arbitrary borders, right? Every border is always arbitrary. So if we zoom in to where I practice in New York, you can see kind of the funniness of this shape kind of in more detail. And you can see, there's a DSA that cuts across New Jersey. Our one in New York kind of cuts across part of the area northern Manhattan, but then upstate New York is a different DSA. Within Connecticut, you can see there's just a huge mess in Connecticut here. And even Pennsylvania, kind of different DSAs. And what that might remind you of, if you're a scholar of history, which I'm assuming no one here is, maybe Adam, is this. So for those of you who are from Boston, I know there are a few. So this is the original gerrymandered district from 1812. There was a governor named Eldridge Gerry, and so this is Eldridge Gerry's salamander, so gerrymander is how it got its name. And it was designed to draw the lines in a way that consolidated people in a very specific way, right? Now, I'm not saying DSAs were specifically designed to create geographic inequity. In the same way that drawing these lines in a certain way consolidates political power, drawing the lines in a certain way consolidates organs and how you can access organs. And so here are DSAs in the United States. And what we looked at was how many organs are recovered or kidneys, I should say, recovered each year compared to candidates added to the list. And so you can see there are a few places in the US, so 5 places in green, in which there's an excess of organs compared to new organs compared to new candidates. So they have a surplus of organs every year. And there are a few places that are this deep red, where there's a really bad shortage of organs compared to people who need an organ, like on the order of 3 or 4 times as many candidates compared to new organs recovered per year. So I want you to pay attention to a couple places just for a second. So look at this dark area in Texas, California, some of these big dark areas, and also some of the green areas like Nevada and Oklahoma, because I'm going to superimpose upon that expected waiting time for transplant that was published a few years earlier than that. You can see those same areas that were red in terms of organ availability are also have the longest waiting times for transplant, and the areas that are kind of had better organ availability have shorter waiting times for transplant, which makes sense, right? The more organ availability, the shorter waiting time will be. And so essentially CAS 250, which is the new allocation system revision from 2021, intended to improve that by saying these borders are too strict. By consolidating or by kind of restricting how organs can be allocated across borders, we're introducing these geographic inequities in access to transplant. And so instead, we're going to do distance-based allocations. What that means is when a donor dies, the local area for distribution is 250 nautical miles around that donor hospital. That way, there's not these strict cutoff borders, where it was if you died in northern New Jersey, you get offered to West Virginia before coming just across the river to New York, right? That doesn't happen anymore. So the first allocation step is to distribute kidneys within 250 nautical miles of the donor hospital. You get a little extra points if you're closer, and then allocation becomes more broad. And what that means in terms of distribution is that here's New York again. Sorry, my figures are always New York-centric, so I know best. But here's New York again. You can see all of these hospitals that are blue dots are donor hospitals that are local to my center, which are a ton more, right, than just the kind of Manhattan and surrounding areas. And as I told you earlier, anytime an allocation rule is made, it does exactly what it is intended to do and nothing else. And so what it did was equalize transplant rates a little bit compared to what was happening before. So here you can see that transplant centers who had average expected waiting times continue to have average expected waiting times. Their transplant rates didn't change. Those that had really long waiting times before, their transplant rates went up, so they improved. And those who had very short waiting times before, their transplant rates went down. And so kind of we're starting to see in kind of that policy doing what it was intended to do. But it had unintended consequences too, because it doesn't do anything that it doesn't intend to do. And part of what the unintended consequence was a great increase in complexity of allocations. You can imagine that instead of having just New York and surrounding areas, donors, hospital, local to my center, that all those other ones were, allocation becomes a lot more complex. You don't need to know anything about how these figures are made to know that the connections between OPOs and centers here look a lot simpler than here, right? There's a lot more connections between the local centers that are local to OPOs. And what that did was it led to a marked decrease in system efficiency. So immediately following the implementation of CAS, you can see that the overall national transplant volume didn't change, but in order to make those same number of transplants happen, basically twice as many offers needed to be made, which is just double the work to make the same number of things happen, which is obviously not great from an efficiency standpoint. That in part led to falling organ utilization following CAS 250's implementation. So the proportion of kidneys that were recovered for transplant but that were not used in a transplant increased to about 25%. Most of these kidneys now are not used because there's just not able to find a recipient in time. And so when we point to the fact that, like, is transplant volume reassuring, I would say maybe the answer is no, because it seems like things are on the verge of bursting at the seams. And I think even the volume alone is probably not enough to make us feel good when we consider demand. So I showed you earlier about waitlist additions versus transplants. But even if we look beyond that, the top line here is the number of transplants that happen per year compared to the number of new dialysis patients. You can see that difference of dialysis minus transplant is increasing, so we're getting worse and worse. This is new transplants versus waitlist additions, the difference. And you can see it only really dipped around the time of COVID when very few people got waitlisted because of kind of the complexity of getting kind of elective, quote-unquote, elective care during COVID. And further, as we'll hear more about in Dr. Purnell's talk, is that even if we talk about who gets on the list, that's getting worse over time too. So right now on the left is the proportion of prevalent dialysis patients who are on the wait list. That's been falling for years. And actually right now it's around 10% with the latest USRDS report, which is the lowest in modern history. And even if some people will argue that this is just because the dialysis population is getting sicker and sicker over time, that's really not true. We showed that even among patients who are young, who have very few comorbidities. So this is the proportion of people who get waitlisted after starting dialysis who are under 40 and who have no documented comorbidities except for hypertension. Only half get waitlisted 5 years after dialysis initiation. And these are the people who might benefit the most from transplant. And on top of that, which we didn't talk about a lot, but I think it'll be important to understand the rest of the talks, is there's increasing kind of, or not increasing, but constant updating of how the transplant system is being regulated. And among these, I think there's been a big increase in pressure on OPOs to say, hey, what's going to be the limiting factor in how many transplants are performed is how well you do at recovery and allocation of your organs. And so starting around 2019, there's basically the announcement of new OPO regulations that will kind of grade OPOs and how well they do at both recovery and transplant of organs. That has added just more pressure to them to do more. And so you might say that I told you over and over again that when we have a problem and make a policy to fix it, it's easy to fix, and that's it. And so when we are faced with this post-CAS 250 dilemma that waitlist access remains very poor, there's a worsening organ shortage that I showed you, allocation is becoming more complex and more inefficient, and there's decreasing utility overall as non-use increases. And there's increased regulatory scrutiny on OPOs to improve this. The question is, why is the system not changing faster? That should be your question, right? If it's easy to fix the problems we want to fix, or at least sometimes easy, why are they not being fixed? And thankfully, I don't have to answer that part of the question. And I'm happy to introduce the next speaker, Dr. Manning. So let me just change this over. No, Dr. Purnell's next. Sorry, my apologies. Great. So it's my distinct pleasure to introduce Dr. Tangela Purnell, who's an epidemiologist and health services researcher with over a decade of experience focused on promoting equity in kidney health, transplantation, and organ donation in the United States. She's an associate professor of epidemiology and surgery at Johns Hopkins and has received several national and international research honors, including being an invited speaker for the National Academies of Science, Engineering, Medicine workshops, and the Transplant Society International Masterclass Series. Dr. Purnell is an executive editor for the Transplantation Journal. She's also a member of the board of directors for the National Minority Organ Tissue Transplant Education Program and the governing board of trustees for the Infinite Legacy Foundation. Dr. Purnell was a 2023 recipient of the National Kidney Foundation Excellence in Transplantation Award. So thanks very much for speaking with us today.
So good morning, everyone. Thank you for answering. I apologize in advance for my voice. My allergies or sinuses have been killing me, so apologies if I sound like, I don't know, a different person. Maybe I should sound like a different person since Ali set me up with this talk. Thank you very much. But I'll be attempting to discuss redesigning the transplant system to promote access to transplant. I have no financial conflicts of interest, and the key learning objectives will be to characterize some of the proposed strategies to redesign the transplant system, as well as describing a couple of recent changes aimed at improving access to transplant. And then finally, we'll talk about what are some of the remaining gaps in efforts and what are some of the remaining opportunities to do a better job, because hint, we need to do a better job. So let's start with how can we redesign the system to address barriers to kidney transplants. And I like one of the questions that Ali proposed in terms of, well, why isn't the system fixed? You know, if we are already doing lots of different things, throwing lots of strategies at it, why isn't it fixed? And the short answer is because it isn't one problem, right? It's a lot of problems, a lot of different barriers. And in order to address this, it will need more than just broad, sweeping national policy changes. We have to really think about all levels of influence for not only the potential transplant candidate, but from the living donor side also, where are the potential donors going to come from? What support systems are in place within our system, within our communities, within the kidney care provider community, et cetera, in terms of providing support for both the potential donor and the potential recipient, and at all stages of this process. So this is a figure from now over a decade ago. I guess I'm telling my age, but I did do this as a student, so I will say I'm not that old. And so I guess I am old. When I tell my nephews I was born in the 1900s, they ask about dinosaurs. So, but the bottom line is, right, there are lots of different barriers at lots of different levels and lots of different stages of this process. And I want to start by reminding us of a report, a very important report that was, let's jump to bullet number 3, commissioned by the NIH and other regulatory agencies. They asked them to examine transplant equity. So just in case someone wants to get me in trouble, a reminder that this was commissioned by the NIH. But this was a report on realizing the promise of equity in the organ transplantation system. And what I really liked about it was the emphasis on justice, fairness, and transparency. And again, another key thing from Ali's talk around trust. And what I like to always point out is that, trust is earned. Trust is not something that anyone owes us, right? We have to be a trustworthy system. And from the data you saw previously, many people do not agree that this is a trustworthy system. They don't even know what we're doing. And in order for us to earn trust, they have to first understand what it is that we're doing and also believe that we are working on behalf of the communities that we serve. Many stakeholders, right, influence access, including, of course, providers, both within the primary care setting as well as more specifically within the nephrology and transplant communities, but also thinking more broadly, the OPTN, OPOs, payers, patients and providers themselves, patients and families themselves. But often when we're thinking about these different stages and different levels and where new programs and policies are being implemented, do we always include the key stakeholders in our decisions to create these wonderful new policies that we know are just going to work? And then when they don't work, what often happens, we blame those same people who were never invited to the table in the first place and say, well, it must be some flaw on their side of the process. But let's talk about, really using some of the recommendations from that report, as well as recommendations from thought leaders in the field. And I inserted a couple of my own thoughts into this as well. And so let's think about strategies to potentially redesign the system. What are the roles of the nephrology care community and specifically also the dialysis providers? So we have to first thinking about, why is it that we still don't have standardized data? I mean, that just feels like the most basic and the most simple thing. We can't fix what we cannot measure, right? If we're not measuring, we don't have the data, we can't evaluate it, we can't advocate for funding to fix this if the information is not there. I think my 7-year-old niece can tell us that, right? So we need to think about it, from every stage of the process, from referrals all the way through what's happening during the evaluation process. We still don't have standardized data. We have to think about early referral and education, about transplantation options, and more specifically, having a checkbox is another thing that is. I'm sorry. I was like, oh no. Ali asked the Southerner with very little filter to talk about these very specific and very sensitive topics, but there must be a reason Ali asked the Southerner with very little filter to talk about this. I mean, some of this is just ridiculous at this point. I mean, it's been decades now. We don't have data. We do not know who's getting referred. We do not know the timing of the referrals. We do not know why certain people are not getting referred. We do not know the quality of those conversations. We don't even know the length of the conversations. We don't know the nature of the content. We don't know who has been educated about transplant as a treatment option. We don't know the nature of that conversation. We don't know the center-based practices that may prohibit providers who want to do the right thing, but who are already swamped with about 10,000 other things trying to keep people alive. I often say it's also ridiculous, the timing of us waiting until people are at their lowest moment to now dump a bunch of very complicated information on their plate while they're trying to stay alive. So why is it that in this field, we wait until that moment to then say, now you have to go and jump through all of these other hurdles? And that's only if we deem you worthy of even starting the process of jumping through these hurdles in the first place. This is ridiculous. Let's think about, of course, embedding transplant navigators or liaison roles, not just within the context of the transplant centers, but just thinking about, again, building these partnerships, right, between dialysis and transplant centers as well as community-based nephrology practices. So instead of asking people who are already well-versed and well-trained in trying to keep people alive, who are already receiving a very complicated treatment, let's think about the folks whose job it is to focus very specifically on transplant as a treatment option and think about building these bridges. So instead of continuing to try and reinvent the wheel, which so far we've not been doing a very good job at, let's think about how do we bring in those conversations from the folks whose job it is to stay on top of the newest developments. And then again, once we finally have standardized data, being sure that we monitor for variations in referral metrics and barriers to reduce bias. Bias is still a very real thing. Racism is still a very real thing. Sexism is still a very real thing. Ageism is still a very real thing. Classism is still a very real thing. There are lots of things that are not documented that we will never be able to document. And sometimes, even despite our best interests, we each have our own implicit biases. So again, thinking about how can we standardize and monitor some of these metrics so that we can minimize the risk of bias. What about the role of the transplant centers? Well, again, standardizing and collecting standardized data and actually providing this data so that we can actually look at it and look at the candidate evaluation process and data and where people are, where are they dropping off, what's happening, what are the different processes at different transplant centers. Again, for this to be such a life-saving procedure and such an important one, we have very, very little data even on what's going on. We don't even know at some places why certain people were approved, why others were not. Like, it's just very basic stuff, right? Thinking about coordinating evaluation and testing, right? So as opposed to asking very sick people with very few resources who are already trying to stay alive, who are likely already going to dialysis, who may already be juggling families and jobs and everything else, to then come back to the transplant center 15 times just to get things done and to then be the point person for making sure that the tests that are supposed to come from primary care made it, and also the tests that were supposed to come from physician number 175 also make it, and the cardiology follow-up that needed to happen is also some. Again, some of this is just ridiculous. Let's think about what are the ways that we can try to minimize some of again, the burden that's being placed on the individual patients. And what are ways that we can perhaps standardize some of these processes? We know that some centers have tried like the 1 day and two-day evaluation processes, and we're starting to get some of that evaluation from things like that. But again, just thinking about how can we build better care coordination. Again, minimizing the influence of implicit bias in candidate decisions. Many of us have been in those rooms where the conversations, I see some smiles, so I know that you know exactly what I mean. When conversations about whether or not a candidate is able to move forward, there are unfortunately sometimes, how do I say this? Sometimes there are assumptions made about people that may or may not be true, but are rooted in our own biases or rooted in our own inexperience with certain situations. So, for example, if we've never worked an hourly wage job, then we may not have the best frame of reference when a patient says, I cannot miss another day of work to keep coming back here for these evaluations. My boss told me that I am going to be fired if I miss one more day. And if we have only worked in salaried positions, it may be very easy to say things like, well, I believe that this person, if they were really dedicated, they would find a way to be here, right? I see some nods. Yeah, so again, thinking about this, leading with empathy, leading with the knowledge that we don't know it all, right? And also thinking about, again, who's not in the room and what pieces of information do we not have. Integrating social supports. So there was a very big push around measuring and capturing social risk. I can't speak necessarily to the nature of where things are with that now because I don't know. I just know it disappeared overnight. So with that being said, I think we have to think about not only capturing data for the sake of capturing it, but for the sake of really deciding how do we invest in supporting patients through this process, right? So not using social needs and social deficits as a way to just screen people out. We need to think about what is it that we can help to do. What is it that should be also our responsibility in helping people through this process? Because again, we've seen the data on mortality, we've seen the data on quality of life. What is our responsibility? And then again, more basic stuff, implementing culturally competent education and outreach, evaluating center level metrics, barriers, and outcomes. So what about the role of policy and funders? So again, of course, Dr. Mann is going to talk more about allocation policies. The first thing, right, we have to address some of these geographic barriers, as well as continued social inequities, including race. We have to think about strengthening OPO accountability and performance measures, but I also want to add a plug here. I've seen some of the press conferences about, oh, you know, we're going to hold these OPOs accountable and we're gonna, and I will just say, it's easier said than done, right? And it's also easier to assign blame to one part of this process versus another, right? And I think that we have to think about the fact that this is a failure on all of our parts, right? And that we need to be thinking collectively about how we can help each other, because our goal is to help the patient, not to think about ways to reassign blame to one party or the other. So even some of the sort of recent rhetoric around shutting down and decertifying OPOs and thinking about some of the metrics that are being proposed, some of it, you know, has potential for good, but honestly, some of it may not necessarily end well for us. If OPOs that are longstanding are just random, or I won't say randomly, but are arbitrarily shut down based upon metrics that may or may not be rooted in evidence, then these OPOs are just kind of randomly merged or randomly, you know, doing some other things. We don't really know what's going to end up happening. What we do know is that those decades of community trust and some of the other things that may be happening at some of the OPOs who may actually be performing well but may not be performing well based upon some of the newer metrics are things that we have to think about as well. So again, not saying that we should not be decertifying, I'm not saying that at all, but thinking about thoughtful ways that we need to move forward, and even in that. Incentivizing increased access to transplant through CMS and payer requirements, right? We know regulations and requirements are often important if we're thinking about trying to prioritize what should happen. Investing, again, in data systems that not only capture social determinants of health data, but also using this to inform support. And then finally, realigning our incentives and resources to address many of these barriers that we already know about, that we have documented for decades. case at this point. We don't need to go and look for this magic bullet for what might be, something that is just wrong with the patient inherently that we have no responsibility to help. We know what many of these things are and what many of these barriers are. And I think that the most important thing is our willingness to try to do the best that we can so that we can help to address the things that we are already aware of. So have we increased access, right? And we heard some of this. One of, Danushka, what's up? What's up, Danushka? So one of the most important, I think, policy changes, of course, within the context of clinical practice has been, the adoption of the race-neutral eGFR algorithms. And of course, the NKF was a very big champion of this. And more importantly, also, some of the policies around restorative justice. And, the evidence has been coming out, and I highlight it here because Danushka and I, along with Dr. Ebony Boulware, have written a couple of editorials about some of the recent evidence that's been coming out around the importance of those policies, even in tackling transplant access issues. And so, again, thinking about what are we doing. And so, and I think you've heard this a little bit. We are, fortunately, from the deceased donor side, if we just looking at overall rates, we are seeing some increases. Of course, there are still some remaining disparities or variations by different social metrics. So, of course, we look at race, ethnicity, by sex, by geography, whether or not, the person is living in a rural versus an urban environment. We do still see some variations, but in general, you kind of see the numbers going up. What about living donor kidney transplantation? So I can tell you, right, like a few years ago, we, unfortunately saw the evidence that suggested that the magnitude of these disparities have unfortunately become worse over time, and when we stopped at 2014. But if we look at more recent data, right, we kind of see the same thing. Look at these numbers. Look at these lines by race, ethnicity, looking at living donor kidney transplant rates. And again, if you just want to look at, for example, the blue line, which indicates white Americans or white patients, and then compare it to the red line. Look at where Black patients are, or even Native Americans. I mean, look at these lines, right? By sex, looking at male versus female, male red, female blue. And then I don't even know what's going on here. This is a lot, with this rural urban. So again, if we're thinking about opportunities, right, to move forward, again, not only thinking about from the patient side, what are the ways that we can also redesign this system to be more friendly to potential living donors? And also thinking more broadly and more upstream, where are they gonna come from? If we don't have healthy communities and healthy environments and healthy families, we don't just arbitrarily ask people to come and now donate a kidney, right? We want to make sure that they are screened and they are healthy, et cetera. So again, thinking about what it would take to even have a supply of potential donors who are eligible to donate. Finally, what are some of the remaining gaps that our national policies and some of our broader sweeping efforts so far have not touched upon? What's up, Danushka? How you doing, Danushka? All right, where you live matters, right? We still know that residential structural racism is a thing, right? And so when we're thinking about, it's a very important thing, regardless of what we call it. We can call it unicorns and apples. It doesn't matter. It's still something that is negatively impacting our health and the health of our communities. I just stop by saying where we're going to find the living donors if our communities are not healthy. And if we know that many of the living donors come within the same family, I think about 90% of living donors may be relatives, where are they going to come from, right, if we're dealing with this? We conducted a study a few years ago looking at sort of what is explaining this disparity in access to living donor kidney transplantation. And what we found was that having timely access to nephrology care, having private health insurance, and again, not living in a poor environment played much greater roles than did differences in comorbidities. So again, things that we can tackle and things that we have not yet to date really gotten a handle on, trying to minimize the influence and the impact. So where does this leave us in terms of thinking about, future research, policy, and evaluation priorities? So again, thinking about how do we tackle these social determinants of health needs, evaluating these policy changes not only for just their overall impact, but more specifically also, what is the impact on existing disparities? Sometimes these policy changes, if we don't think about equity-centered impact, sometimes they can make disparities worse. Developing, again, standardized metrics and sharing the data for evaluation. Again, identifying upstream barriers, in particular when we're thinking about living donations, so that we can help remove some of these barriers. And then finally, thinking about policy shifts, and these broad sweeping policies must be transparent and must also be participatory. People will not just buy into something that you tell me is wonderful if I have no idea who you are, or I have no idea who was involved in making these changes. And then also thinking about centering the patient and the community voice. Let's center the people who are most impacted by this residual issue. So enhanced funding is needed to do that. Restored funding is needed to do that, right? To think about supporting community-rooted priorities, engaging patients and communities in the design of these policies and programs, thinking about the lived experience, co-developing materials and programs, ensuring transparency, and then remembering that, again, trust is earned through our actions. So call to action in summary. Advocacy, again, we have to push for data, policy, and resources. We have to think about partnerships, collaborating across all of our key stakeholders. Again, not assigning blame to one group when in reality we are all failing. So we should just all, get together. We're one team. What is it? One band, one sound. We are one team, right? And so we have to think about what is it that we can do and where can we fill in some of these gaps. Thinking about, again, screening social risk, not just for the purposes of excluding people, but so that we can think about what support is needed in standardized care. Patient and community engagement improves relevance and trust. We need to do that. We have to have policies that realign transplant incentives and funding is needed to be restored so that we can do this work correctly. And then finally, we have to support each other. This is very hard work, especially now. Some of us have more targets on our backs than others. And if you are aware of some of these people who have targets on their backs, even if, you want to kind of remain in the shadows, give them a hug, give them a high five, give them a kudos, give them a kind word, buy them a coffee. I don't know. Do something to acknowledge, right, that you understand that this is hard work, this is important work, and that we're all in this together. Thank you very much. That's all I have.
Okay, we're going from former Excellence in Kidney Transplantation winner to this year's Excellence in Kidney Transplantation winner by Dr. Rosalind Mannon. So Dr. Mannon is a professor of medicine, pathology, microbiology, and immunology at the University of Nebraska Medical Center, where she's the vice chair for research and associate chief of research in the Division of Nephrology. A Duke-trained nephrologist, Dr. Mannon is a translational investigator in late kidney allograft outcomes. She's published over 250 peer-reviewed publications on chronic allograft failure and post-transplant complications and therapeutics. Dr. Mannon is a past president of the AST. She currently serves as the deputy editor of the American Journal of Transplantation, medical director of the SRTR, and trustee of the BAM Foundation for Allograft Pathology. She is a recipient of the AST Senior Achievement Award in Clinical Transplantation, although I don't think you're that senior yet.
I don't feel that.
And the TTC Trailblazer Award and American Association of Kidney Patients Medal of Excellence in Transplantation. It's really a pleasure to have her here today. Thanks, Dr. Mannon.
Well, I have a lot of big shoes to fill, but thank you for inviting me to speak. And I will tell you that I don't have the answers. I'm probably going to give you more questions. And first start off that I slightly changed the title because I used this accessibility review that we need to do in our medical center, and it said fair. It should be fairer, not more fair. I have a lot of conflicts, but I will say the most important for this is that I am the medical director of the SRTR. I am not here to represent those views. I am here to represent my own views today. So we're going to talk a little bit. I've had some great intros. Some of this will be duplication, so I apologize. I'll talk a little bit about how our system operates, talk a little bit about organ retrieval and the source of donor organs, and then look at some factors for the disparity. I'll probably stimulate more discussion than I actually will have solutions. So shockingly, none of us before me showed this figure, but this figure was derived from the Task 5 from HRSA to provide a human-centered understanding of the transplant system. And the patient is down over here, the central line of these many stops along the way. There's a whole part about deceased donation. There's a part of living donation. The transplant centers and referring physicians, we already heard about the challenges of that communication. Of course, we can't forget the payers that play a major role in this. But, and trying to get the patient transplanted into long-term graft survival is our primary goal. And then we have this big line here, the regulator. And I will tell you that transplantation is the most regulated field of medicine in anything in the United States and probably within the world. So you've heard about waitlist information. This is from the SRTR, the OPTN report that just came out. This goes up to 2024. It's a little bit higher, about 147,000 total candidates on the waiting list. This dwarfs the liver, the heart, kidney, and the kidney exceeds all the other organs, including heart, lung, and small bowel. And this is the transplanted number in 2024, huge disparity. Even if everybody was activated, we still account for about over 7,000 deaths per year on the waiting list, and that equates to about 20 to 25 individuals a day. It doesn't sound like a lot until you really think about those patients and have to deal with it. And again, similar disparities that don't seem as exacerbated, but are also primarily a problem within all the other organs. And so overall, when you look at the 2024 numbers, about a quarter of those individuals received living donor kidneys, and we have a growing number of prevalent kidney transplant recipients. Not a discussion of workforce today, but that is a major prevalent patient population that the average transplant center is not going to continue to be able to handle. You saw the slide from Ali's previous talk about allocation rules, and this is federal statute. This isn't policy, this is rules that exist in this country that are supposed to be followed by the OPTN. And I highlight three, did the best use of the donated organ, designed to limit waste, avoid futile transplants, promote patient access. I mean, these are expectations and requirements, and they have to be reviewed periodically. And we've seen some of that periodic review, but I'm going to take you a little through history because I'm older than many of you in the room, that when transplant started, the allocation was really matched on blood type and our very early understanding of HLA, which was A, B, and DR antigens. And it was really the Southeast Organ Procurement Foundation known as CEOF. It was like a mom and pop operation. There were many busy women involved in this in transplantation, including centers like UAB and Wake Forest that created some of the forerunner of understanding of allocation. And then over time, they became the United Network of Organ Sharing and became a formalized entity. The UNOS was the OPTN contractor from 1984 until about 6 months ago when their contract was halted by HRSA. But again, they were responsible for allocation. And so in the 80s and 90s, a lot of this was priority and waiting time. And I was a medical student, so I don't really remember most of that. It just didn't really impact me. but I was in the transplant field in 2000 when there was a new final rule that was created following up from NOTA, talking about survival over geography and really creating a nationalized system. And we heard from Ali about CAS as another innovation and this CAS 250. And I don't want us to forget that the previous Trump administration shockingly had this executive order to advance kidney health. And this order includes provisions to improve transplant. And so when we lobby, when we visit center offices, and they are Republican offices, we remind them that this is part of what they are expected to do. And right now we're in the midst of this modernization that I'll try to describe. This is a new federal law, probably the first update since the final rule in 2000. So what have we done to expand the donor pool? We've heard about this Kidney Donor Profile Index, which was really instituted in 2014 to rank deceased donor kidneys with an expected longevity compared to other donors. It's important to point out that this calculation is based on the prior year. So when this was instituted in 2014, currently the KDPI is based on last year's data, and we know that these populations have changed, as evidenced by the fact that the higher KDPI, 85 to 100, meaning that a KDPI of 85 has about a 15% better outcome than the remaining number of kidneys. So this is not a score you want. You want a low score, like 20%, which means you're in a percentile that's going to do quite well. But this percentage of older, more medically complex individuals is increasing, and as pointed out by Dr. Purnell, we have removed race as well as Hep C status. We've advanced over the last 10 years through this public health service risk analysis. So these were individuals that are felt to be highly at risk for transmitting HIV and Hep C primarily. Again, rules that were created by the CDC more than 10 years ago that were very risk averse, and again requires patients to really be willing to accept those. I think we've talked about the major advances in hepatitis C. I think this was a game changer just in general for the health of the country, but now the utilization of these donors is really something that we all have standardized policies for, and there actually are guidelines by the AASLD. And then, of course, the major change in HIV policy back in 2013, signed by President Obama, allowing the use of HIV-positive organs into HIV-positive recipients and the removal of research requirements. Unfortunately, I don't think that has been a terrifically big improvement for HIV-positive patients who, even and of themselves, though are surviving longer periods, also have multiple comorbidities and maybe make them less likely to be waitlisted, but also not retrieving organs from HIV-positive individuals. Here's another big change that has occurred over the last few years: donation after termination of cardiac death. You can see over time that, this was proposed back in 2000. It was being done in Europe and selected centers in the U.S., but the population relative to all deceased donors has gone up. In 2024, it represented about 35%. This is coming up to almost 50% of deceased donation in the United States. And why is that? Well, catastrophic brain injury probably has better care. We do have seatbelt laws in some states. I think the frequency of overdose drug deaths now is different, but anoxic brain injury are still really more frequent. There's more recognized value that these organs work. There had been sort of a reluctance about the outcomes. OPOs are really under strict methods and metrics, and I'll go over those in a few more minutes. But I think one of the things that's really advanced the use of donation after cardiac death is movement away from static cold storage of retrieved organs into maintaining viability of those organs. And this slide just summarizes these ex vivo machine perfusion. And I'm not going to that's a whole separate talk of normothermic and what fluid is being used. But the forerunner was really here, the lung. The heart used to beat, but the animation isn't working today. But it does make you sort of say, wow, this is incredible. And it really did. It transformed the opportunity to take organs that would otherwise perhaps be, though they were authorized for, and they would potentially be retrieved, they would not be utilized. The kidney's kind of boring. It's here in the little box. But in all honesty, these technologies are advancing quite quickly into trials. This is an example of one mainly for a lung, but again, to optimize organs. So maybe getting a suboptimal donor, maybe extra warm ischemic injury or cold ischemic injury, but optimizing the metabolism and figuring out, maybe this is a doable organ. And I would assure you that, I'll show you some data right now, that, the use of ex vivo, this is data that I pulled about a couple of years ago, 2018 showed here versus 2023 for each of the organs, and you can see sort of a relative static nature of lung, because they already got their act together. But there's been dramatic increases, especially for kidney, in the use of ex vivo perfusion versus not. And you can see also that nearly half of the organs that are put on these perfusion systems tend to be cardiac death donors. So I think that this technological evolution and revolution is facilitating our use of these organs and providing excellent outcomes. Now, while I say that, and the transplant rates for lung, heart, and liver have been improving over the last few years, in particular due to ex vivo, we're not seeing the same trend in kidney. In fact, we see a lower transplant rate with the use of ex vivo, and it's a complicated research question in trying to understand the data, which is somewhat limited by the way we collect the specific data. But it wasn't something the New York Times felt unhappy to complain about, and it's okay. I try to but I do read the comments. I read all the public comments because I want to understand what people are thinking. This organ discard, this is recovered organs but not transplanted, is rampant. It really has continued to be a challenge. Why is it? I think the organ procurement organizations, in all honesty, have had intense metrics to recover every single donor. I think, as Ali pointed out, transplant centers tend to be risk averse. They don't want delayed graft function. They don't want to have poorer outcomes because they'll have lower GFR or worse cardiac outcomes. We do a lot of donor biopsies. Some are mandated within the OPTN, but the most aren't. But we find that, about almost 40% of organs are discarded or not utilized because of these biopsy findings of sclerosis or fibrosis. I think there's some geography and system variation levels. And then we talked about logistics, but this airport here is it's different than I remember it. It's open all the time, but when you live in a city like Birmingham, like I have, or Omaha, they're only open until that last flight from Las Vegas gets in, and they keep the bar open, by the way. But in all honesty, the airport shuts down at midnight, and that's it. And you don't see it open again for operations. The first flight coming in is usually not until about 6:30 or 7. And if you're sending organs back and forth, that's a barrier. That's a real problem. This is another problem that we're dealing with. It's called allocation out of sequence. When OPTN policy is you have a waiting list, and you go from person to person to person to person until you get to the next person to accept that organ. But out of sequence is when you skip individuals to put this organ into someone else. And it's a very complicated problem. It's been studied by my colleague here to my left, associations that these are quote unquote higher risk organs, or certain OPOs that perform this, and the institution of CAS. And along the lines, you can see that allocation out of sequence rose dramatically, really, I think in part to mitigate the non-use of these of potentially transplantable organs. And when HRSA put its memo in about allocation out of sequence, putting a lot of specter on how this is being utilized by centers, AAOS went way down. And this paper is a little bit later than the Adler paper, these data that I pulled. But you can see that maybe there's some stabilization here in non-use, really hard to know. But these processes are really intertwined. You heard about the NASM report, so I won't harp on that again, but really I think some of the key pieces of this report that you'll hear echoed in the OPTN modernization is this outdated IT infrastructure, unacceptable. Gathering data, unacceptable. I could tell you 1,000 reasons why these things are happening, but if I don't look at the data, it's all sort of mental impression. Public dashboards, we do have some that are available, but understanding the metrics and the patient's experience. And it hasn't fallen short that the legislative branches have been involved. We've had more public hearings on these issues than probably any other medical problem in the United States. And indeed, many of us watched in anticipation at this hearing by HHS. We thought it was actually going to be closing down the use of donation after cardiac death after a review by, I think it was Senate Health Committee in July of 2025, but instead they finally closed down a poorly performing OPO. No offense to those of you that are from that area. It was always going on, and it took a long time to close it. And this is just some of the many headlines. I highlighted a couple because it has really created distrust in the community. And the Donor Alliance has said that after another, in this commentary about how many individuals deregistered as being deceased donor because of their feelings that their organs might be taken inappropriately, not utilized, and/or their families subjected to suboptimal care, much like the book from Robin Cook called Coma, which most of you probably haven't read. And again, Ali talked about this. For the first time in my career, the number of kidneys recovered has gone down. It's astonishing. What about living donation? Can we create something there? Again, stagnating rates, and you heard some of the reasons why. Kudos to us getting the Honors Our Living Donor Act approved and went into law. That was a combination of people in this room and multiple societies, but I would say NKF and ASN worked hard to remove the statutory requirement that the use of this National Living Donor Assistance Fund, which is money to reimburse individuals for things like housing and daycare while they're donating, was now means tested to the donor, because for a decade it was means tested to the recipient. Why? An outdated understanding of living donation, that many people donate, but they don't get to put their kidney into their family member. And so it wasn't a well-off family member maybe donating. The kidney it has nothing to do with who the recipient is. And we've got more work to do, folks. I highlight two in purple using the colors of NKF's theme because these are things we're working on the Hill right now. Increasing this eligibility rate for NILDAC to 700% over the federal poverty level, which I will assure you is still quite low, and capping this to about 10,000 so that there is enough money within NILDAC. And importantly, oh my God, this thing I've been advocating for like 15 years, the Living Donor Protection Act. This will mandate insurability of our individuals that donate and codify existing FMLA benefits. So for a long time, the federal government wanted the states to do it. It's impossible. So we're getting close. These have already been dropped. They've already had co-signatures, but we need more oomph. There are a couple of other things I'll point out. The Living Donor Volunteer Act, which is talking about a lot of different educational aspects, which I think are very positive. I don't know if it'll get much traction. And then this other more controversial End Kidney Deaths Act, which would provide a reimbursement credit of tax credit over 5 years to individuals that donate. A concern, I think, for many of us that this might incentivize. We've talked about the OPOs. I guess this is now 54 since I made this slide. These are not-for-profit organizations in different donor service regions that are authorized to pay, and HHS is really authorized to sort of manage them. I've talked about these federal hearings. Here's one in September of 2023 that found that there was this massive increase in pancreata that were being recovered. Well, they weren't going into the recipient list, which is quite small, about 1,200 in the United States. They were being utilized for research, but that research benefit counted as a retrievable metric. And so that was like a little, and I published an article, I don't think I put it here, but that really sort of manipulated one potential metric, and it's gone now. And of course, this energy and commerce hearings about the safety of deceased donation after cardiac death, and I think this shows just really poor protocolization of these methods. There's multiple guidelines of how they're doing from surgical societies. It was unconscionable what happened back in 2022. So what's going to happen to the OPOs? Well, this slide now is outdated because in March the CMS proposed a new rule, but the current status was that there were 3 tiers of performance: low, medium, and high. You're all tied together. There was, shifting around here, but the poorest tier 3, was threatened to be closed. They would be shut down, and then the other OPOs would pick up that covered lives. And the scary thing is when you look at the lowest tier, you're talking about 25 65 million potential covered lives. So the takeaways here that I'll just say is that the new rules are looking to consolidate the OPOs back into the donor service region so that the tiers will be aligned more with the DSA, but also a very strong focus on these medically complex. The definitions remain to be seen, but I think we're waiting to hear the responses to this rule. And finally, right now, I think all of us, many of us in this room who do policy, supported the Securing the U.S. OPTN Act. The idea that there would be a need for an evolution, a revolution in the changes in the care of how the OPOs, how the whole system operates, and awarding contracts to private and public entities by the Secretary of HHS, and really codified into law a couple of years ago through Assent. What's happening? Well, the cap to funding to HRSA to manage the OPTN is now at $57 million. It's been uncapped. We're advocating for even more money next year, like in the $65 million. They have already competed multiple contracts within the OPTN. UNOS is no longer the sole proprietor of that process. The board had to be reseated, so they removed the UNOS board and had transplant centers pick new individuals. There's still a management contractor pending. All committee work is currently on hold. With the focus, it sounds great, technology, data transparency, and quality. But the reality is that not everyone is happy. This is Macy Levan's letter when she resigned from the OPTN, the UNOS board, when it became clear, very concerned about the lack of transparency and the modernization efforts with contractor management, and sort of disruptive, that this was quite disruptive but not really helping. I do have a hot link here. I don't want to represent anything that HRSA says because they say that they want to be the communicators, not me or any of us in this room. They have reseated this board. As I mentioned, committee work, except for the members and professional standards committee, is working. They've integrated the scientific registry subcommittees as their goal. They're going to move the human-centered design, analytic methods, patient and family subaffairs, and SRC into the overall OPTN. Basically, the contract to SRTR has been minimized to predominantly collecting data and providing those data reports with a lot of emphasis on transferring all that to this cloud-based system that's run by CMS. So really disappointing, and really working through with HRSA with a lot of assurances that they're not the old HRSA, they're the new involved HRSA. You know, overarching goals, who isn't for this? Accountability, patient safety. This OPTN 411 apparently gets 300 calls a week about concerns about patients, how they're treated in the hospital, deceased donor relatives, that kind of thing. Public trust, I'm all for it, I agree. And then this data systems, well, this has been probably the slowest and most disappointing. They do have the ventilation patient form, but the notion of having this sort of collective data about transplant center referral is a priority, but we were told it will take time. I will say that it's not called the ASTP anymore in the federal government, but the Office of it's an office that looks at data accountability, has taken over that this pre-transplant evaluation piece will be part of their key agenda this current year. And then it's not gone past on some of my colleagues about how to do this, how to increase patient access. You know, do navigators work? Really hard to say. But I thought it was an informative piece and worth reading, although, again, lots of suggestions that may or may not happen. But if the federal government continues to press on, CMS has created the Center for Medicaid and Medicare Innovations has the IOTA model, increasing organ transplant access. I talked about this at the pre-meeting last year. It's a 6-year model. It takes over about half of our transplant centers in the United States, with really admirable goals in terms of, you know, increasing the use of deceased donation, more living donors, more support, care coordination, greater equity, and most importantly, costing the government less money. And these are the centers in dark blue. I've been privileged to not be one of those centers, but it also is good because then I can go to somebody and say, how's it going? Again, this change affects probably about 2/3 of our patients. We have about 30% primary Medicare and then 47% mixed, but only the minority are not. There are 3 domains: the achievement domain, which is transplants, probably the biggest number of points. Efficiency is based on the offer acceptance, and then this unadjusted quality outcome. And so there really was an opportunity that even if you increased you're a moderate-sized program doing 200 a year, that's probably pretty good, probably more than moderate, and you increase your volume by 10 a year, you could potentially make $1.7 million to the hospital. There is some updates right now. The VA transplant programs, thankfully, are excluded. That's a complex system I know a lot about, but not for today. And not in a bad way, it's just too complicated. Removing programs that perform less than 15 transplants. And finally, after multiple responses to CMMI, the composite graft survival will be risk adjusted. So, that makes total sense. They really pushed back, and I'm not sure why, but they kind of get it now. And then eventually there'll be transparency of program function with public data. Unfortunately, we don't have that data yet. The data release will be coming out sometime around July 2026 or after. There was an internal dashboard for centers that were in IOTA that they could use, but this was a UNOS tool, and I don't know if this tool migrated to HRSA, but internally transplant centers are supposed to be getting reports. So we know kidney allocation is not optimized for any of the goals we hope for right now. I think alarming is the downturn of organs. We have to recognize that donation after cardiac death is the new normal. It may not affect the patient necessarily, but as a group, when we're performing transplant, we need to understand that trend and be supportive. And ex vivo perfusion, I think, is really an expensive tool, but it is really optimizing organs even beyond the kidney. The OPOs and centers each have sort of tangible differences in terms of allocation optimization. We have to make sure that there's oversight. HRSA is taking that lead, but we need accountability from them. And, debates over the allocation seem to have to really align with patient expectations. And I do think the federal government has its own personal expectations. And again, being vocal and looking into what they're doing is really critical. And we have to depend on the OPTN board to do that. So I'll stop there, and hopefully we have a few minutes for questions. Thanks.
Perfect. So Drs. Purnell and Menon will join me up here on the table, and we'll take questions from everyone. If when you come to ask a question, if you don't mind introducing yourself, please, so we know who's asking.
Hi, I'm Mike Krause. I now am at the Indiana Donor Network, so I'm in the OPO world. So I've spent 30 years in academics. I was born in the mid-1900s.
No dinosaurs.
30 years in academics, then I would decide to go to the dark side, and 7, 8 years in industry and dialysis organizations, and now I'm tying my ribbon with procurement. And it's an interesting and fascinating thing that you touched. One thing you said, trust must be earned, and I'm certainly agreement with that, but the problem is mistrust is easier to earn. And when Bobby Kennedy gets up in 2020, last year in July 2025, even before the Miami thing, and says HHS finds systemic disregard for sanctity of life and organ transplant system, it hurts all of us. So we've seen registrations, people deregistered, people not registering. The number of potential deceased donors is only 0.3% of deaths. So it's not everybody that can be a donor. And when you cut that pool, the number of deceased donors went down. Now, the OPOs in response, not all of them, but most of the good ones, and there are lots of them, improved the ability to get it. So you didn't mention NRP, but that's a critical part.
Yeah, and I didn't want to get too technical,
Right,
but
no,
I
I
wanted
understand.
this audience to know that we have these technologies
Right.
that are really critical for providing donors, and OPOs are embracing them because the scientific data is good, and I think they're approved devices. But that's a good point. The NRP.
Yeah, so what I'm saying, there's a couple of things that we got to focus on, making it easier to get on the list. 18% or less of the patients on a transplant wait list is immoral, right? We have to do better.
Immoral. We're going to use that.
And we have to make the best of every gift.
Yep.
And this is the second part. As the OPOs become more aggressive, we're able to deliver much more organs per donor, get more gifts, but we have transplant centers that turned it down. New York, you don't, right? So I know I can take a KDPI kidney in 98% and call your transplant surgeon and they'll take them. What hurts me is when I got one kidney that gets taken in New York and another one I can't place. So we have to get the surgeons to understand, as you said, better perfusion, NRP, things that actually make a huge difference. You have to take those organs, right? We have to figure out a way. When I have a cutoff of KDPI of 85 and I don't want to look at the organs, I don't grow. And I think we have to look at KDPI again, because it's not as useful as it was in 2014, because it's a completely different world.
It's different, and it's related to the prior year. So you sort of lose the longitudinal aspect, and unfortunately, I don't think there'll be a permitted, I hate to say that word, but a permitted or supported recalculation by HRSA. I think this will have to be something that will need a paper or two. We'll have to push the data out publicly. There'll have to be debate, and then the board will have to step forward and say to HRSA, this KDPI is not working. And attending the public parts of the board meeting, I don't have a good feeling of how it's operating right now. I think they're just
So if you look at the literature, the KDPI is losing its value. So above 85 to 100,
it's a big spread. Yeah,
it's a big spread, and those kidneys all work the same. So the 5-year survival of those grafts in patients is the same. It's not what it used to be. The straight line is gone. And so we have to, as a nephrology world and a transplant world, begin to understand those things. Otherwise, we'll continue to throw those perfectly good organs away.
Thanks very much. Let's we can go to that side. Yes.
Hi, my name is Arshia Ghaffari. I'm a general nephrologist from University of Southern California. Thank you for your talks. They're great. My comment and question is relating to the finances. Thinking about the key stakeholders, other than the patient, the hospitals and hospital systems, and the large dialysis organizations. The hospital systems don't see organ transplant per se as a profitable thing. Most smaller programs operate at a loss. And then large dialysis organizations realistically see patients being moved away from their business. So how do we incentivize these folks to be part of this process to make things better?
Are y'all looking at me for this? No, I'm just playing. Yeah, so one of the things that I can recall, one of the conversations with even a transplant coordinator in terms of thinking about, well, why is the communication sometimes so poor in terms of the follow-up, the updates, et cetera? And one quote that stuck out to me was that, the transplant centers get paid based on the actual surgeries, not based upon the potential people who may or may not, make it through the process, who may change their mind, who may, never make it. And so sometimes the ratio of the staffing doesn't always match like who's coming through the doors. And that kind of stuck with me. I think that one of the bigger things is this is, when we think about ethics, et cetera, this is more of a societal cost. And I think that, unfortunately, part of this will just have to become part of these regulations. I think that, really thinking about how do we even move some of these decisions outside of the individual stakeholder purview when society as a whole is operating at a loss, when we leave people, on dialysis for life, and we are losing their abilities to fully participate in society, et cetera. So unfortunately, I agree, especially in thinking about, the big business of dialysis. That's a lot of money. Usually I do the slides to show you how many cars you can buy and how many homes you can buy with the amount of money that CMS pays to the dialysis centers. But, I didn't do that one today. But that's a big business, right? And so I think that having to think outside of the purview of what's in it for me versus moving more towards this is what is happening to us. And this is what we now, we're required to be done to fix this. I think we have to kind of change our mentality.
I mean, after Trump signed that executive order, there were changes through CMMI and two care models, right? I think it was KTC that supported both home dialysis therapy and transplantation, and the transplant piece was, I think it was successful, but it was a money loser within CMS. So then you're like, wait a minute, is that my problem? But these innovation models are really to do that. I was always told that if you hit at least 100 kidneys a year, you could break even. And everybody goes, what about the downstream factors? Well, you've already heard from Tangina that people come to the center, but we don't have enough slots for echoes or MUGAs or pap smears or dental clearance. I mean, we just don't, and we don't do it. And our center really heavily relies on community-based care. And oh my God, Epic, Care Everywhere in Epic actually facilitates that, because once the patient signs in, we can get those reports. And it was harder in Alabama, I would say, because patients really didn't have resources. They could get to and from the dialysis unit, and it would have been nice if we could say, hey, could you help us out here? This patient is waiting on a colonoscopy. You got a group of docs in town that could do it, and we'll take it. But this whole notion, I'm looking at Eugene Lin, and I don't want to call on you, but I'm sure you know the answer.
Call on him.
Yeah, but certainly can address some of this financial inequity and disparity, because it takes 3 years for the equalization, I think, financially of transplant to dialysis, and that promise keeps CMMI interested in transplant. I appreciate that they've had those programs.
Thank you.
You're not going to get up, okay.
I know.
Very disappointed.
Well, Adam's there too, so he might,
Adam,
he
okay.
might have an answer and then a
You're in
question.
trouble.
I could stand here and answer for Eugene, maybe to some extent. I have another question first, and then maybe we can come back to the financing, if that's all right. This is Adam Wilk, Indiana University. Really appreciated all of your presentations. Thought they were super well organized and put together. Thank you for them. Question is mostly for Dr. Purnell, since you spoke to this issue most directly, but I'm sure all three of you could speak to this. A couple of your slides alluded to what needs to be better coordination between dialysis units and transplant centers on the pre-waitlisting side. I've seen a number of instances where some of those collaborations work well and they don't seem to be very long-lived, and the manner in which they are structured seems to be pretty inconsistent. I wonder how you would characterize what we should think of as the priorities, or maybe the key components of an effective collaboration and long-term lasting partnership between dialysis clinics in an area and a transplant center.
That's a great question. I actually think that your group, because I am quite aware of your own research, may be even better equipped to talk about some of this. But, I'll start by saying that another thing I've observed, especially now, is the really high rates of turnover for staff members who are working in both facilities, especially in the transplant world. For some reason, there's been a lot of turnover. And so when we're thinking about building, like these longer term collaborations, again, another thing I heard was it takes a minute just to get it set up, to get it started, to build, like even that camaraderie, so that now people know this is why I'm coming. I'm not coming here to steal your patients. I'm not coming here with some nefarious intent. I guess you kind of are stealing it, but you're not stealing it just for the sake of stealing it. You're really trying to also help to adhere to, what our guidelines and what our regulations say should be happening in their case, and so the ones who have who've shared with me that they've gone in trying to make the case that I'm here to really help to alleviate your burden. We have the regulations saying that this has to be happening. We have the information in this standardized way. How can I work, in conjunction with you? How can I help you? And so that has been, at least a starting point. But to your point about, they come in, it works for a little bit, it disappears. And I think part of that is the turnover, unfortunately. I think that, in order for this to really make an impact, again, there has to be more leadership kind of at the institutional levels. So it has to be a priority, right, for both, that dialysis center as well as for, the transplant center, et cetera. It has to be a priority from someone other than individuals often using a lot of their own personal time and using a lot of their own personal bandwidth trying to make this work. And when they disappear, all of the institutional knowledge and all of the gains disappear with them, or, it's funded by a grant, and when the grant ends, again. So I think that buy-in has to come at a higher level, and there has to be consistent resources, dedicated resources to do this. I also think that there needs to be consistent conversations that are kind of happening both at the frontline staff level as well as the institutional levels, so that people can really understand that this is a true partnership and we're working towards a common goal and kind of coming to a consensus on what is this goal going to be? What does this look like for us? What does it mean for us? How does it fit into our day-to-day? And what are, sort of the consequences of us not working together? So that's sort of just off the top of my head. But
I'm going to add a comment. So why isn't there interoperability of the computer systems of dialysis units to us, right?
Yes.
Like how many times, in days of old, patients trotted in with massive amounts of paper, but I knew quickly how to read the dialysis sheets and find out, were they adherent, were they not, were they coming off early, did they show up in time, what was their pre and post dialysis gain, why was their echo so poor, why was their right-sided pressure so high and they get negated. And we don't have that interoperability. That is a priority and something we've talked about at a strategy session at the ASN a few weeks ago, back in March, just sort of brainstorming what are things that we need. And that's not replacing the personal relationships. When I started out, we probably did 20,000 kidneys less a year, and our referral patterns were very specific at Duke. They were, NIH, don't even ask, that was a very different program. But even at UAB, we had physicians we had trained who were now in the community that specifically sent Mississippi patients from Tupelo to Birmingham because of this one-on-one relationship. And so you did have a name and you did have a number and you could call, and you hope that these things were affected. But we could never follow up because you move on to the next patient to get them transplant ready. The other thing is, for patients that may be in the room, the SRTR does have a patient website explorer that gives you a sense of the BMI, your where you live, what's your likelihood of being alive, and you can compare centers. I think that's great, but I think many people don't have the means to fly across to Omaha because they'll wait 9 years less for an O kidney than they would in Birmingham. And so I think that that's helpful for patients, but it doesn't solve the overall referral crisis that we have.
I love that the personal relationship can be a big part of that, but to Dr. Purnell's point, as soon as there's turnover, that relationship evaporates.
And the dialysis, let's just say the dialysis unit workforce is threatened, right? It's been threatened for a while, and maybe there's been some solutions suggested here, this program, because that's a real problem for us, maintaining and capturing, keeping our nurses and staff continuous.
Really like the point Dr. Purnell made too about having leadership make it a priority consistently. That can help sustain the relationship. In my experience, it tends to be easier to help them make it a priority if the finances are aligned.
It's always about the money.
For a lot of folks, it is. KCC and some of these other models have been trying to align these incentives across these organizational divides, but not without a lot of bumps along the road.
So I'm going to ask you a question. What do you think? What's going on with IOTA? Do you think it's sufficient? Do you think we're going to see an uptick?
So I'm really excited about how many conversations I think transplant center leaders are having with central hospitals about the question from the previous commenter about, is transplantation really a money loser for the organization, or can we recount some of the related expenses and services that are brought into the organization all along the evaluation pathway, bringing additional revenue into the system that historically haven't been counted. So I honestly don't know if transplant is a loser for many organizations in the way simple calculations might lead you to believe. So I'm excited about that. I don't know that all of those conversations are leading to a lot of investment in transplant centers the way that CMS would really have wanted. And so are we seeing greater staffing on the pre-transplant side or post-transplant side? Maybe at some centers, but I would tend to guess maybe not at as many as we would like, not at all of those, however many 90-plus transplant centers who are in IOTA. So I think we're going to see some progress, but maybe not hit goals we might have set.
And I'll say that there is no defined industry standard for the number of patients followed by a pre or post-transplant coordinator. Sent out those surveys every year, and comparing a center doing 50 transplants a year to one doing 350, I am almost certain the 350 transplants had many more people and probably more higher-end customers, so to speak. And I know which centers those are. But I think that that's another piece that for the staff is really overwhelming, even with checklists and reminders and web page, things that you have tools on your computer to help you remind you to follow up patients. But it does get to be exhausting, especially if you're presenting 15 patients a week at a mid-major center in the Midwest. At UAB, we would present 60 to 65 a week, and keeping the details. Thank God for the EMR. I can't believe I'm saying that, but yeah. I think that there are.
It has its points.
It has its points. I mean, bringing in those big folders and sifting through them. But I do think that we have to be cognizant of the manpower and the physical resources. Operating rooms, for example, that are quite limited. And I'll say that transplant is often not. Kidney is considered not urgent, emergent, whereas liver is. So kudos to, it's good when you have a liver kidney surgeon in your program, because they sort of say, wait a minute, this is important. But if it gets to be diametrically opposed, the kidney team here, the liver team, liver's making all the money, there's going to be a subtle utilization of operating room space and deferment to them. And this isn't in the U.S., this is happening outside the U.S., particularly in Canada, where certain organs get order preference. It's not spoken about, there's no research, but they talk about it in terms of what they make available to certain programs, certain organ programs.
Thank you all. Thanks.
Yes.
Thank you.
Hi, I am Laura Missett, and I'm the Deputy Division Director for the division at CMMI that houses IOTA and KCC. Please don't throw tomatoes at me. We're trying our best.
Hi, welcome.
Something that really broke my heart last year was the scrubbing of all the data, and I'm going to say some forbidden words, so please don't tell me. The social determinants of health data, the health equity data, and all of that work.
Wait, I missed the second word.
The health equity data and the social determinants.
I missed it again. Can you say it one more time?
I'm just wondering what advice you would have for people at CMMS who are trying to measure these things but aren't allowed to say the thing. We talked about geography or income, or do you have insurance or dually eligible?
Child. I think I can't say out loud, unfiltered, what I think about the current state of things.
Okay, we can talk later.
I will say, with that being said, many of us who are conducting research in this space are going through, a lot of the same struggles in terms of knowing that there are, AI algorithms that are pre-screening our grants and pre-screening our papers, looking for keywords, et cetera, et cetera. Sometimes there are recommendations that they kind of say, well, don't use this word, use that word, or sometimes you even hear back and kind of say, well, if you fix this or revise that, we might reconsider it, but otherwise we don't, and da-da-da-da. And, I have kind of two sort of chains of thought in terms of thinking about how I'm approaching it, even in trying to encourage my students who are coming along now and who are questioning, what did I sign up for? And what I kind of say is, we want to, there are battles. We have to pick and choose different battles, but the goal is to win this war. And this war is going to be, won over multiple generations. And I think that there will be times, I believe there will be times again, when we are allowed to say out loud equity and all these other words. But, in the interim, nothing is stopping us from doing the work that we know needs to be done and needs to be important. And I kind of, jokingly said in the beginning, I don't care if you call it unicorns, uniform, I don't care what you call it. I mean, as long as it's not derogatory. We have to think about how to advance the work within the constraints of kind of currently where we are. But then on the other hand, we also have to, or, if you would like to, what I do is try to still find spaces where I can say out loud, this is what it is. Call a spade et cetera, et cetera. So it's sort of like those two, kind of trains moving forward. We're all trying to make it to the track and trying to keep going forward long enough to be able to hand this baton over to the people coming behind us. I don't want us to fall so far behind that by the time they pick it up, it's, kind of like a lost cause and it takes an additional generation. So I think keep doing the work. Sometimes, I don't know, what do they say about a tree bends with the wind so that it doesn't break. Sometimes that's sort of been, the answer we've gotten to try and continue to move forward. But also stay true to who you are. Don't allow, like this moment to, change you or to change your motivations for wanting to do the right thing.
All right, thank you.
So that brings us to the close of the session. Thank you again to our wonderful speakers.